If anyone needs me, I'm available by cell phone.
Is now a good time for me to grab some coffee?
Hi, everyone. I would like to welcome everybody to our second COVID-19 pandemic program. We are now in an update mode. My name is Ariella Novak. I'm the director of the Jewish Community Relations Committee for the Jewish Federation of Northern New Jersey. And we are privileged enough to have 3 now physicians taking part in this program today, where we're gonna have your questions answered. We've had many questions submitted. We've written them down and we plan on answering as many as we can today in our half hour. Without further ado, I'd like to introduce Dr. Tzvi Marins, who will be moderating our program today. And please, in the chat, you are welcome to place your questions throughout the entire program, and we will feed them in throughout the session. So please do place your questions on the bottom. I know I will be placing mine. Dr. Marins?
Thank you, Ariella. I would like to welcome all of you to our COVID-19 pandemic update sponsored by the Jewish Federation of Northern New Jersey. We will be having a conversation with leading infectious disease physicians. This is our second conference on the topic, and we will be picking up where we left off last month. My name is Tzvi Marins, and I am privileged to moderate this panel. I am a pediatric cardiologist at Columbia with a local practice in Northern New Jersey. I am also a past president of Jewish Federation of Northern New Jersey and currently the chair of the Endowment Foundation Investment Committee. I am so very proud of our federation. The professional and lay leaders alike have performed extremely well in difficult circumstances. The staff has risen to the challenge to continue to help those in need wherever they may be. Federation is worthy and indeed needy of our ongoing support so it can continue its mission to help Klal Yisrael. I also would like to thank Ariella Novak, Director of Federation's Jewish Community Relations Council, for putting this panel together. COVID-19 has been a particularly difficult disease to control and dominate. There are many peculiarities associated with it that continue to require further elaboration. I hope that we will be able to shed some light on this peculiar and enigmatic disease. We have succeeded not only in flattening the curve in the New York, New Jersey area, but there has been a significant decrease in the local hospitals of the number of patients who are actually admitted and those who are on the ventilators. So we are now in this region on a diminishing part of the curve. Now let me introduce our 2 panelists. Dr. John Sensikovic is an adult infectious disease specialist, primarily in Edison, New Jersey, and affiliated with multiple hospitals, including JFK and St. Michael's Medical Center. Dr. Aryeh Baer is a pediatric infectious disease specialist, a pediatric colleague of mine, affiliated with Hackensack Medical Center. Now the format will be a relatively quickly moving panel on the current important issues related to COVID-19. I will be alternating questions between our panelists. If you have any questions, please feel free to submit them using the Q&A function on the bottom of your screen, and Ariella and team will sort them out and pass them on to me as appropriate. We hope to be completing this panel by 9:30, and I'd like to welcome John and Aryeh. Let's jump right in. So Aryeh, let's first talk about testing, because it seems to me that the testing is a major component of how we're going to manage this in the next few months. Can you give us an update on the PCR testing, and then I'll turn to John afterwards and ask about the antibody testing.
So the PCR testing, we certainly here in Hackensack, we have limited capability still. We're testing pretty much everyone that comes in, but we do have limited amounts of testing available. Fortunately, we have the homemade one the homemade PCR testing for the DNA. It's not a perfect test though. It's not a perfect test. It doesn't detect all people. So there are people who have it who are negative from PCR by testing in the throat or the nose. It's not the perfect test.
So just to clarify, of course, the PCR test is the nasal swab test.
Correct.
That is done through the nose, and it is a test to show if you have virus sitting in the back of your nose.
Right.
Okay.
Right. It's for active disease, presumably for active disease.
Got it.
The other issue is that, as Ms. Novik was telling us, it can stay positive for a while afterwards, that test also. We're seeing people who are weeks positive in. And the truth is we don't know what that means yet. We don't know if it means that the person is actively shedding live virus. We just don't know.
Okay. So John, there's been a lot of talk now about antibody testing. Can you give us first a brief explanation of what the antibody testing is and what the significance or lack thereof is?
Certainly. The antibody test, as with many infectious diseases, is an indicator that someone has been exposed to that agent and they have developed an antibody response. The presumption based on past infections is the presence of that antibody is protective, that these individuals have had the disease, they developed an antibody to it, and they have some degree of protection from that infection coming back. And as a matter of fact, that's taken a step further. One of the treatments might actually look at using that type of high titer antibody to treat patients. We cannot be 100% certain at this point how much protection is there and how long it lasts, but certainly it correlates. The presence of antibody correlates with that individual having been infected and now has an antibody defense against that virus.
Okay, good. So Aryeh, tell us, what is the status of rapid testing? Is there a test available that can give us a diagnosis quickly? And I think of that mostly in terms of how are we going to function in the real world, going onto airplanes, going into the theater. Is there a possibility of being able to stand online like a TSA environment and be able to have a rapid test to let people go in or not go in?
Yes, the PCR test can be done rapidly. That said, again, the question is the reliability of, can you trust a negative result to mean you're not contagious? And that's not entirely clear cut that's the case right now. It's helpful, it's certainly helpful if you have somebody who is positive, then okay, then they have it. But a negative, it's not 100% reassuring. So it's hard to know what to do with a negative result.
Got it. There was a question actually that someone asked if the nasal, it's a good question, if the nasal swab PCR can be falsely negative, what's the gold standard? And so the answer is, I think, a clinical syndrome. If you look like you have COVID, then you have COVID, even if your testing is negative.
Right. So that's one that, if the labs look like it and the imaging looks like it and everything else looks like it, then you probably have COVID. Obviously, we don't know 100% for sure, but the labs are characteristic enough and the imaging is characteristic enough that we could say that someone probably has COVID. The other thing is, there are times when, at least in the adult world, in the adult medicine world, they'll get specimens from sputum, from phlegm that the person brings up, or the person's intubated, so they get a deeper specimen from the lungs, and that's positive, even though the upper airway was negative. So we know there are definitely cases that we're missing with the nasal and throat swabs.
Good. All right. So let's now shift a little bit, and we'll ask John more about the pathophysiology, about the way this disease causes its harm. And it seems to me that it's not absolutely clear yet if we know exactly what's going on. But John, you want to talk a little bit about how? Is it an infection? Is it immune response? Is it some other issue in terms of the pathophysiology of this disease?
Currently, we certainly understand part of the pathophysiology. As with many viral infections, this virus attaches to the membrane of cells in the respiratory tract, especially lung cells and lung tissues, causes an acute inflammatory reaction there and a pneumonia. And that is the disease that we see most commonly related to viral infection with corona. There are other complications that can occur as well. We are now seeing evidence of inflammation of the heart, so-called myocarditis, associated with this virus. We are not certain yet how that mechanism occurs, whether it is somehow directly affecting the heart. We are also seeing, besides that, other complications. There is a syndrome known as a cytokine release syndrome, a very acute inflammatory reaction that occurs in the lung when someone is infected with this virus. When that happens, the inflammation makes the breathing really not effective, and that's why these people lose their oxygen. And now some of the disease that's being described in young children with heart involvement and a systemic reaction, which may be related to this virus. So even though the main essence of this infection is a viral pneumonia, a viral pneumonitis affecting the lung, we are now seeing more and more variants on this, other complications that appear also to be related to infection with this virus.
Good. So Aryeh, John mentioned the pediatric syndrome, and obviously as pediatricians, we find this to be an intriguing subset of COVID. Do you have, you want to just briefly describe this pediatric entity and any ideas about what is causing it?
So first thing I want to say is it seems to be rare so far. We're seeing cases, but it's not an overwhelming thing like they're seeing in the adult world with all the cases of severe pneumonia progressing to breathing failure. But what we're seeing is, hyperinflammatory syndrome where the body's immune response seems to be out of control and causes damage to multiple body systems, to the heart, lungs, kidneys, liver, and kids go into shock. They drop their blood pressure. They can't maintain their blood flow to all their critical organs. Some kids are having what we call a Kawasaki-like presentation, where the Kawasaki disease is an autoimmune illness where the body makes inflammation against blood vessels of the heart. So we're seeing things like that where kids will have rash and red eyes and a swollen lymph node, a swollen gland in the neck, swelling in the hands and feet, and a rash. We're seeing that in some kids. And some kids in New York and Europe have been reported to have heart problems, have dilation, widening of the coronary arteries of the heart. So we're seeing these hyperinflammatory shock syndromes, again, some Kawasaki-like in presentation. Again, not a lot, but we're seeing some like that. Okay.
John, let's pivot now into a little bit more of epidemiology and immunology. This is the main question that we're all asking is, if you've had it once, can you get it again? Are you immune? And can you still be contagious even after you've had it? John?
Excellent questions. I wish we had 100% of the answers, but based on our knowledge of past somewhat similar diseases, we certainly have now shown in several respects with this virus, the contagion is probably the highest amount of virus someone is shedding appears to be the highest a day or two before the symptoms and for several days after the symptom onset. Even though we can still detect viral antigens beyond that point, the degree of infectivity is probably not as high. It's transmitted as a respiratory virus in droplets from people coughing and sneezing, although you can also, for a period of time, pick it up by touch from the environment and inoculate yourself by touching your face, your mouth, your nose. So we know that that viral syndrome occurs through that pattern. But it also appears, as with most other viruses, once that antibody response occurs, it gives a fair degree of protection, at least to that current infection. How long that lasts, whether that persists indefinitely, or whether that response would be magnified again, as it is with many diseases, if someone is exposed again, we do not know. So basically, we don't know how long that protection lasts after the infection. Time will certainly give us that answer.
Okay, so that is a good segue, I think, into the vaccine. So we'll start with Aryeh, first of all, because vaccine, even though it's ubiquitous in all over with many different diseases, it's a little enigmatic to most of us. So Aryeh, can you first tell us what exactly is a vaccine? How is it developed? And then we'll turn to John and ask us about the timing and comparing it to other diseases.
So vaccine is you introduce either part of a germ or an activated part of it, or some altered version of it that does not cause disease to the person to make an immune response. That way, when your body actually sees the germ, when you're infected with it, your body recognizes it instantly and forms an immune response, and you don't get disease, or at least you get a less severe form of the disease. That's a theory. Vaccine development, it takes a while because you have to find the part of the virus, or a way to inactivate the virus that won't be harmful to people when you inject it, but will elicit that good immune response. We'll get the body to respond to it in such a way as to be protective. So that's kind of the trick. You have to kind of run that fine line between efficacy, effect of the vaccine, and safety. What else do you want me to cover?
So you're basically saying that the vaccine works by simulating the disease in you, so you don't get the disease, but you get the response to the disease.
Right, but not the infection. That way, when you come in contact with the infection, your body fights it off.
So John, can you tell me then why might not there be a vaccine? There are times when, let's say for HIV, there's no vaccine. Is there a possibility that there won't be a vaccine for this virus?
I guess there's always a possibility, but seeing what's happened in the past with somewhat similar viruses, other coronaviruses, the immunological response seems to be compatible with the development of a vaccine that will be protective. So even though we can't be 100% certain until we get the results from some of the studies that are starting now with various components, and different vaccines may act differently, the belief is that based on past experience with coronaviruses and other viruses, a vaccine with efficacy is achievable with this virus.
Okay, so I think of all the other vaccines. So you have, let's say, measles and mumps. Those vaccines last almost forever. Then you have flu vaccine that you have to take every year because of mutation, but it still is effective. And then there's no vaccine for HIV. So based on past experiences with coronavirus, is this anticipated to be a vaccine that might last for a very long time? John?
It's hoped to be so, but we cannot predict because we don't know if there will be a mutation to this virus, and it could appear in a different form where the vaccine would no longer be effective, and that happens not uncommonly. So time, unfortunately, will tell. If there is a mutation with the new strain that becomes spread, this vaccine could lose its efficacy. That's the reason why with influenza, we need a different vaccine every year because of those mutational changes.
Okay, so let's now pivot to medical treatments. There was a lot of hype early on about hydroxychloroquine and azithromycin. So Aryeh, first tell us what is the science database status of hydroxychloroquine and azithromycin in the treatment of COVID?
It's still being looked at in studies, but it's really fizzled to a large extent, those two medications. Largely because of the potential side effects of arrhythmias, of abnormal heartbeats that can occur, that can be fatal when you use those two medications together, or even using the hydroxychloroquine alone. And the benefit really does not seem to be there in terms of what people are seeing. So whereas before, hydroxychloroquine was considered our standard of care, I mean, if you came into the hospital with COVID, we would give you hydroxychloroquine. We're not doing that off the bat anymore. We've backed away from that. It really does not seem to have the efficacy that we were hoping, and there are potential toxicities, potential side effects that can occur. So
And
not being used.
it really goes to the need to have randomized blinded studies,
Right.
because early on everybody said it works, and then they were interviewing rheumatologists who said hydroxychloroquine is safe and we've been using it for 30 years, and all of a sudden people were dying. So this is why it's very, very important, obviously,
Right.
to have real good controlled studies on these medications.
Which is very hard to do when you have a disease that's staring at you and
people are dying.
People. Right.
John, tell us about a medication. The first medication I think that has some data to show is the remdesivir. Can you tell us what it is and what you know about it?
Yes, remdesivir is an agent that has antiviral activity, but in this instance, it's an intravenous medication that actually blocks the inflammatory reaction that is promoted by this virus. And by giving the inhibition to that inflammation, that is how this tends to improve the patient's response to the virus. And that drug is being used now in clinical trials, as well as in instances where it can be obtained on special consent.
Okay, so again, that's with trials, and we're excited about that. And then, of course, if you read the Israeli news, the Israelis seem to be at the forefront in some of the research on this. There was recently, I think 2 days ago, the discovery of a monoclonal antibody. Arya, are you familiar with that? And can you comment on it?
Yeah, there are a few places that are reporting monoclonal antibodies, and we don't know if that's going to be something that's effective. So monoclonal antibodies, that involves looking for an antibody that's effective. So from blood donors, looking for an antibody that's particularly effective, and taking that antibody and making lots and lots of copies of it that you can get and give to patients, right? So manufacturing that antibody in a lab so that you can then give that to people. The idea being that that antibody will bind to the virus and neutralize the virus. We don't know yet if it's going to work. So there's a whole issue of, since this is all new, the preprint data that we're getting. That means before things go through a medical journal and are reviewed by other doctors and physicians and scientists. So we're getting a lot of information from the news now, which is not always the best thing, because we don't know if it's going to work. Maybe it will, maybe it won't. There's not a lot of precedent for using monoclonal antibodies for treating viruses. Possible to work, but we don't know yet.
Okay. John, in terms of actual in-hospital treatment, are we any better at taking care of very sick COVID patients now compared to the way we were 2 months ago? Or are we still, besides medicines, are there maneuvers? I know we were talking about being prone position, but that was early on. Are there any new ways that we're treating that would make it a less serious problem when we're in the hospital?
We are using these agents that were mentioned, and I think in some instances, we believe we are seeing a response. Certainly going from the remdesivir to the tocilizumab, which is the anti-inflammatory agent, to the hyperimmune serum, we're using all of those because some of these patients are critically ill and we don't have a lot else to offer but supportive care. We are seeing what we believe are some responses, but in order to be certain, it's going to take a lot more data and a lot more cases. And I'm sure there are other medications that are going to be coming along and other treatments that are going to be tested. And hopefully we'll come up with several agents that are shown to be effective against this virus. The other part of it is supportive care. When these patients wind up in the intensive care unit on a ventilator, that ventilator care that we give them, that general medical care that we give them, all of that taken together, hopefully in many instances does help.
Okay, now the big question before we conclude. What will it take before we can return to normal? Big question. I'll first let Aryeh start with it, and then John can finish it up.
It's probably going to be a little bit of a while. And normal may not be the normal that we knew before February. We need good testing. We need reliable testing. We need a vaccine. That's what we really need, a vaccine. We need to have people that are immune. Once 60 to 70% of people are immune, that's when we can interrupt the transmission. So we can find the vaccine, that will be the real game changer.
Right. John, anything to add to that question?
I think the other issue is with more testing, we'll have a better idea of how many people might have already been exposed and infected with mild disease and have some degree of protection. So there's an entity that's described as herd immunity. If enough of the population has antibody, it may well protect the rest of the population to some extent. So that's one of the things that's going to play into this. How many people already have antibody from mild or subacute infection? We do not know. So that data, I think, is going to be critically important, as is the vaccine, as is therapy, other therapy that may come along, and most importantly, common sense approach to avoiding patients who are symptomatic to help stop the spread of the disease.
So it's a big challenge because, of course, when this started, everybody said a couple of months and then there'll be a vaccine, and it seems to be dragging out longer and obviously causing a lot of stresses. And that's where I think I agree with the common sense approach, is that we can't be black and white about this. We just have to mitigate risk and be careful and cautious. We didn't talk at all about PPE and hand hygiene. We spoke about that a lot last time, but that is certainly a part of it. All right, so I would just like to end with a short message. We've all been struggling with this disease. We're worried about our families. We're worried about our friends, our country, and even about ourselves. There have been and will be casualties along the way, but we will ultimately, I'm convinced, dominate this disease. In the meantime, let's try to take advantage of the gifts that this crisis is sending our way. More time with family who reside with us in our homes, a greater appreciation of our own health, and a more focused perspective on what actually matters in our lives. Resilience, which is our ability to adapt to adversity, is one of humankind's greatest traits. Things may be different when this is all over, but they may well be better and improved. Thanks to both of our panelists, and thank you all for joining us. And please be safe and stay healthy.
Thank you for joining.